Welcome to Envue Health, Founders Friday show with your host Dr. Lecresha Sewell and Shermaya Holland.
Hi, and welcome back. I am Dr. Lecresha Sewell, a board-certified women's health nurse practitioner and the CEO and co-founder of Envue Health. So welcome back. Thank you for tuning in. Make sure that you do make it your business to go follow us on all of the socials. We are on every social media platform that you can think of. And if we're not, please let us know. But make sure you go to our Facebook page, our LinkedIn page, our Instagram page, our Blue Sky page, and our threads. And also make sure you go to Indie Soup to like and subscribe so that way you can continue following us. So yeah, I'm really excited to have you all here today to just kind of give a talk about my specialty, which, like I said, is women's health. I've been in healthcare for 20 years now, which sounds crazy to say out loud. I had to think about it. I was like, oh man, how long has it been? It's been a journey. Clearly, I haven't practiced all those years. I mean, I aged gracefully, but not that graceful yet. I became a board certified women's health nurse practitioner in 2014. And I've been practicing ever since. I also was credentialed as a sexual assault nurse examiner as well in 2013. So I've done a lot with women and just women's health in general. My day-to-day looks very different now as a provider versus being on the staff working as a staff nurse in postpartum and some antepartum. And those words mean, let me break that down for the people that don't know what postpartum means. And I speak very fluidly just because it is something that I know. But postpartum means after childbirth, and antepartum is during pregnancy. So while I was a staff nurse, I did care for women during that time frame. And I also worked newborn nursery and with some neonatal NICU care with some of the babies that were withdrawing. But moving forward, my current career now, and really our topic of the day is women's health, which, like I said, has been pretty much most of my career. As a board certified women's health nurse practitioner, I see patients for gynecology services and obstetric services. Gynecology is like just women's health in general, and obstetrics is related to being pregnant. I'll just keep it very simple for you guys in that way. So I don't deliver. I have no desire to deliver, honestly. I'll just be frank about it. I love you guys, but that is not something that I am interested in. I leave that to the people who are blessed to have that gift, blessed to be able to be present during that time frame of labor and delivery. But again, that is not something that I have ever actually done. With that being said, those are labor and delivery is typically done by a certified nurse midwife or obstetrician, which is a physician, and that can be done in many different settings. But I'll get back to my day-to-day. With that being said, I see women for things such as coming in for your annual exams or your preventative wellness exams. When it comes to getting just your, as we call it in our world, your well woman exam. So typically we start doing cervical cancer screening at age 21. I think most women think just because you get a speculum in your vagina that you're actually getting a pap smear, but that is not the case. Pap smear is specific to cervical cancer screening, and I can't express that enough. I don't know how many times a day I explain that to patients. A lot of patients think when they go to the emergency room, when they have a pelvic exam, that they're getting a pap smear. And again, that association is that a speculum, that duckbill looking tool that goes in the vagina, is actually just getting a pap smear. And that's not the case. Oftentimes it is just a pelvic exam that is being done. Pap smears are not required to be done annually if everything is normal. That used to be the case. I know back when It used to also be the case that as soon as you were sexually active, they were starting to screen you for cervical cancer. And then also that included human papillomavirus, which is the leading cause for cervical cancer, also known as HPV. So with the Pap smear screenings, we do that screening as well, human papillomavirus screening on that. So like I said, we start at age 21, and depending on your outcome, we use the ASCCP guidelines in order to guide us and direct how we manage those results. So really that is what mainly we look for when it comes to making sure that cervical cancer is prevented. Cervical cancer is so preventable with accurate screening, accurate follow-up. If you let it go, I mean, it is something that could potentially take your life. I mean, but again, with proper screening, it is very much so manageable. And we have very few deaths for those who actually follow up and make sure that that it is managed properly. So yeah, compliance is key to ensure that we save lives on our end and in your own. So yeah, with that, also, like, even though that we don't have to do cervical cancer screening every single year, I tell my patients, I still want to see you back annually. There are a lot of things that we can find in just doing a routine exam outside of just doing cervical cancer screening that you wouldn't even think of. I mean, even just doing, taking a listen to your heart and lungs. Now, it may not be as thorough as when you go to your PCP, your primary care provider, but we do a good job of making sure we include that, checking your thyroid. Oftentimes we'll find that if you are having issues with your period, it could be a matter of thyroid issue or just some type of hormonal imbalance that you may not consider. All my life I've bled super heavy, or all my life I've had irregular periods, and that's not necessarily something that we would consider normal. So we would evaluate to see what the underlying cause may be in your annual exam, or even if you decide to do a problem visit. What else can I express? Also, one of the things that I often hear from my patients who have had hysterectomies. So a hysterectomy is when you get your uterus removed, and that could be for various causes, whether that be a fibroid issues. And I know we've done quite a bit of coverage on our social media about fibroids and what that is. So if you are unfamiliar with fibroids, please visit our socials to learn more and what that could potentially mean. But and a lot of times when you do have fibroids, that can cause significantly heavier periods than what you would typically have. So therefore, again, that could be a reason why you would need your uterus removed to manage that. Also, if there is a situation where you have uterine cancer. Again, various reasons, but most of my patients, they'll say, oh, I thought that I would never have to have any type of pelvic exam again just because they've had a hysterectomy. And that is totally not true. You do still have a vagina. You still have a vulva, which is that outside area. And there could be skin conditions that we look for. We do vulvar biopsies in the event that you have like lichen sclerosis, which again, these are skin conditions that we look for when we're doing a pelvic exam. That you may not be able to put a mirror down there and see. Like we really check for those things, making sure your vaginal cuff is intact, and that's where your vagina is. Well, where your cervix once was, that's where your we call it a vaginal cup. I guess that's the best way that I put it, where things are put back together. So we check that because sometimes that can dehiss or come apart. And that would be problematic. So again, there are lots of reasons why we still need you to come in for your annual exam, still get checked out, and make sure all is well. Included in your annual exam, if you're 40 and up and no family history of breast cancer or anything prior to, then that's pretty standard. We'll start ordering mammograms with that. We want to make sure that you're getting your breast cancer screening done, and then making sure that we are able to follow up if there are any issues with that. There are more screenings that may be required if there are issues with the routine screen that is typically done. And you would go to either a diagnostic place or a hospital. There are some clinics that are able to perform breast exams, but typically they're done in those types of settings. not prostate exams, excuse me, mammograms. Before 40, you can also find issues with your breast. With that being said, there are lots of benign conditions that can come about, such as like fibroadenomas. Those are very common and unproblematic generally, but still something that you would want to have that awareness of. So coming in, getting your annual exams, once again, us being able to identify those things and further evaluating if there is some finding that may be a little bit different from the norm. From there, we also can order colonoscopies. It is recommended for us to, as Black people, to start getting screened compared to the general population earlier, just because when we do find it, it is generally more advanced, excuse me, in the event that it is present. So we start at 45. Some patients opt to do a Cologuard, which is where you take your stool, your stool. I think everybody knows what stool means, but you take that sample at home and you send it off to be evaluated. And if people are, so everybody has their reason. And I understand some people don't want to be put to sleep. Some people don't like the idea of even having a scope done. But nevertheless, making sure that you have some type of colon cancer screening if you are Black, African American, however you identify, starting at age 45. And then in the event that you have a family history, then again, we would manage accordingly. So that is another thing. Like, finding out your family history before you come into an appointment is so important. That really does help guide us when it comes to how we manage your care. So in the event that you know that your grandmother had ovarian cancer or some type of cancer, or just something that may be pertinent, or maybe you don't think is pertinent, but just know that if you present it, then we can ultimately plan your care according to your needs and not just based on our general knowledge of what we think you would need. So basically more tailored care. We will be able to do more individualized care, shall I say, in the event that you are very familiar with your history. So that is one of my biggest asks of my patients, like, especially if it's my first time meeting them. And I'm like, you only know so much, but I challenge you next time when you come in to try to get more information. So that way, again, we're making sure that we are taking care of you well and meeting your needs. Beyond that, on the pregnancy side, I talk quite a bit about gynecology. I certainly see patients throughout their pregnancy. Typically, I stop seeing them about third trimester, but it's critical that we try to get patients in first trimester. First trimester, we are doing all the screenings, finding out if there are any potential abnormalities that could be present during the pregnancy. So first trimester screenings, making sure you're taking your prenatal vitamins. And again, if you have medications, any chronic conditions that would need to be managed, it's ideal to get all that addressed first trimester and then continuing on care throughout the second and third trimester. We really try to ensure that we're capturing all patients first trimester. And so since I don't deliver, I work hand in hand with the folks that do deliver, which is pretty awesome. We collaborate together to ensure that the care is what each patient would need based on their needs. I know a lot of patients used to think that you would get ultrasounds every visit, and that's truly not the case unless it's indicated, unless you're really high risk. That isn't something that we do. We tend to do a dating ultrasound, which will confirm your dates. Like your estimated due date and how far along you are in simple terms. And then from there, we would typically do an anatomy ultrasound, which is, in my practice, we do it with the high-risk doctors, maternal fetal medicine docs, so that way they are able to truly see if there are any issues that need to be addressed with the anatomy. But nevertheless, outside of that, if you don't have significant complications, I would say do not expect an ultrasound unless there's like growth issues or like growth restriction issues or something that is complicated in the pregnancy. Those two ultrasounds are generally what you would expect if you have a fairly healthy pregnancy. And that's a good thing for for the patient and baby, but I know sometimes it can be a bummer. But just know that we are taking care of you. We are listening to baby's heart tones. There are so many things that we can assess during pregnancy as well that we look for. And I could run it down quite a bit, but I won't do that for the sake of time. And then also one of the things with menopause and postmenopausal patients, menopause, we consider 1 full year without a period. And postmenopausal is after that time frame. In the event that you have some type of bleeding after you've gone 1 full year without a period, we want to know about it and we want to see you as soon as possible to further evaluate you. Once you have that full year without having a period, we want to make sure that it is not some type of medical emergent situation where you could potentially have a uterine cancer. So typically what happens with that, I just did one today, actually, you do an endometrial biopsy where we take and we just suction some of the tissue off and send out of the uterus and send it off to be evaluated to see. We also like to do an ultrasound, a transvaginal ultrasound, which is where we put a probe in the vagina and check to measure out your lining to make sure that it's not too thick, because there could be other abnormalities besides cancer, which cancer is the worst case scenario, but we still want to figure out why that is happening. So ladies, if you happen to have any type of bleeding after you have gone 1 full year without a period, do not delay. Let us know. That is not something that we would consider normal. So that is one thing. And then in regards to, and again, that's just a very brief overview of my day-to-day. I mean, clearly I screen for sexually transmitted infections. I've been seeing a lot of syphilis. Ladies and gents, be careful and be mindful of your health. Treat that with Bicillin. But yeah, screen for all those things, bacterial vaginosis, all the types of vaginitis. Be mindful of your feminine hygiene, the products that you're using. That can make a huge difference too in your vaginal health. And I can't emphasize enough with diet. Like I tell my patients day in, day out, what you put in, you put out. If you are eating trash, just know that your body will let you know in various ways. So if you keep finding that you are having this horrible pH shift, water intake might not be there. Your diet just may be needed to be addressed. Lots of different things. So also just be mindful of that too. But those are some other things that I see a lot of patients for. On sexual health, as far as being a credentialed sexual assault nurse examiner, I don't take cases now, but when I did take cases, I took them at the teaching hospital here in Louisville, University of Louisville Hospital and Center for Women and Families. I could only see patients at Center for Women and Families that were sexually assaulted if they did not have severe trauma. We couldn't do all of what needed to be done to document and assess the trauma at the Center for Women and Families like we could in the emergency room. So that credential, pardon me, I'm getting on certifications, credentials, that credential, I only did adults. There are some people that can do pediatrics as well. I cannot do children. I have a soft spot for children when it comes to those things, and I just know my limitations, and that is off limits for me. But so I only did adults, and really there were teens and like teenage girls on up, not like infants and babies like some of the folks do. And I even had some prisoners because they had reformed some of the laws or something here to where prisoners had to automatically be brought in and be assessed in the event that they were assaulted. So very, very difficult being on call for those cases. Anytime I got called in, I knew what it was for. I knew that it would never be anything that would be positive in regards to their experience, but me being in the position that I can do the best that I can to help them move forward by collecting the evidence, by submitting the evidence needed for their cases in the event that I was called to testify, being able to ensure that I had collected all anything that could ensure that their case was presented in the best light. So it was a lot of that, a lot of reassuring the patients that, they're not alone, providing them with resources. And even the prisoners, being violated as a male for them and those types of circumstances, something that wasn't necessarily desired, shall we say, having them break down, crying on me, just trying to console them, and they are like broken. So it's just seeing, and even domestic violence cases. I remember having one lady who came in on a stretcher and a C-collar. So I don't know if you guys, those white, well, it was white back then, but basically they had to stabilize her neck because she had been beaten so bad. I thought she was coming in for a car wreck. When I walked in, I thought I was actually in the wrong room. But she had been beaten so bad by her significant other with a baseball bat. Most of her teeth were missing. Like I said, she was on a stretcher, a C-collar. So doing all that, it took me hours to document all of the trauma that she had, all of the findings there. But moving forward, she recovered, thank God, and was able to move past. But in all my years, again, I have truly enjoyed every aspect of what I've done, whether that be a staff nurse working in the postpartum unit, antepartum unit, newborn NICU, all the things that have to do with women, being able to ensure that women, who are generally the foundation in the family when it comes to health, are in their best health that they can possibly be in, and letting them know that it's okay to put your health first. Oftentimes we find that women tend to be on the back burner. We're scheduling appointments for the spouses, for the significant others, for the children, but oftentimes waiting till it's too late to really take care of ourselves. So I can't emphasize enough how important it is to make sure that you, as a woman, if you are a woman, if you identify as a woman, but if you have the female parts, or anybody in general, that you are taking the steps to make sure that you are getting the preventative care that you need, and not just assuming just because it's always been this way that it's normal, or just because my mom said this or my grandmother said that or my friend or whomever. Make sure that you know for yourself what your status is, your health status is, and that you are being proactive about it and advocating for yourself when you are in those spaces to do so. So with that being said, I hope you enjoyed our episode so far. Thank you for tuning in, and I hope this has been informative for you. Don't forget, again, to follow us on all the socials, Facebook, Instagram, LinkedIn, Threads, Blue Sky, and make sure you like and subscribe. Indie Soup. Looking forward to continuing these conversations. If there is anything that you all are interested in and wanting us to speak more on, happy to do so. Until next time, stay well, take care. Bye.